All right, we are live, and here we are for a common sense approach to medical billing and coding. We have a pretty big webinar here tonight, so we're going to give it some time for people to log in. With that said, I'll launch my slides here, Joe, and I'll have a few slides to go through here once I see the numbers jump up here. Steve, I can see you. Can you talk so I can make sure we can hear you?
Yep. Can you hear me?
Oh, perfect. Awesome.
Great.
Joe, you there?
I'm here.
Perfect.
All right.
Yes, sir. It's going to be a good night tonight. There's some new guidelines out here in the E&M coding, and kind of excited to hear it myself. So let's see here. Numbers are climbing. Good. Thank you for everyone that's here tonight. I'm going to start into the slides here of this housekeeping. So this course is being recorded. A replay will be sent tomorrow, about 14 hours from now. There'll be an email that is sent out, and it will have a replay. I will, with Steve's permission here tonight, I will download this recorded webinar, and I will put it on our YouTube channel for you those that want to hear it again. It's Optometric Education Consultants on YouTube. We have all of our past webinars on there. So you need to, if you want to go there, you can do that and listen to it again. I'll probably have that up there by Wednesday or Thursday. There's always a link from our website there also. There is a required survey that will be sent out 2 hours after tonight's webinar. You'll get an automated generated email. There's a survey link in there for all the crediting boards that are out there. Please complete that survey. Actually, Dr. Ice asked me to put a little extra comment in there. Please give him feedback on how he can make the presentation better. Decrease your bandwidth at home. If someone's gaming, watching a movie, if you're watching football on your computer and another screen there, this will compete with bandwidth, especially at home with the gaming and spouses, maybe streaming movies. That's where we get a lot of issues. When people shut that stuff down, then things become a little bit better. Vanessa, who was just on, she just logged off. She's our conference administrator. She will send information to COPE. She will send to Arbo. She'll upload it for the Florida people that are here tonight. This is able to be done for Florida. She'll send that to the Florida board. You will also get an email certificate, and I'll remind you that at the end also. So here is a little bit of the screen. I'm going to see if I can get my turn on my whiteboard here. This little button right here, this little red button that I'm circling, it expands and contracts the screen. Right now, the way it's pushed, my screen is wide open. When I push that, it collapses the screen this way, and you get functionality to all these buttons over here, where we will launch the handout, which will be under Files. Steve was gracious enough to have 2 handouts here. Steve, I'll launch your handout for tonight pretty early once you get started. And then you have a guide wherever you want me to launch that. Make sure you mentioned about that. You sent that to me earlier today.
Okay. Yeah, and you can launch that right away. That's fine.
Both of those at the same time?
Yeah. Mm-hmm.
Okay. When you get started, I'll do that, and I'll let people know when I do that. Over here is also where the polling questions are. We need to make sure this is live and interactive, so make sure to reply to the polls. Some people like to put their answer in chat, but that's how you get function. So this little red button shrinks the screen down. That's very important for you to have the functionality of those buttons. So with that being said, let's do a test polling question here to see if everyone is doing well. So I'm going to start the poll, and I'm going to turn on that they can see the results. So this is practice, everyone. This is not the CE part. Looks like a lot of people have gotten in, which is great. Here is the polling question. Where is your practice regarding COVID-19? Closed, open for emergencies and urgencies, open with reduced schedule, and open and back to normal patient count, and busier than ever than before. I'm going to clear this off here so that all the writing, and turn this off. And it looks like we have a pretty good amount of people here that are responding to the polls. Looks like you guys have found it. Remember, make sure it's shrunk down. It's down under polls. People are replying. And I'm going to end the poll here shortly because it looks like the numbers are slowing down. And the poll is 2% are closed. 0% is open for emergencies and urgencies. Reduced schedule at 36%, 40% are back to normal, and 20% or 19% are busier than ever. Joe, what do you think of your comments on that since we've been doing this?
Well, clearly things are getting better for everybody. You know, so many people were closed. They were only open for emergencies when we were doing this really at the height, really the height of the pandemic and the actual lockdown. And now there are a number of people who are busier than ever, or mostly people are back to normal, which is terrific.
So we're about to get started here. Joe, I've been doing a lot of talking. I'm going to have you introduce our speaker tonight. So we're about ready to get started. Steve, do you have your slides ready to be shared there?
Yep, I will do that now.
Okay, perfect. Go ahead and take control there, bud. And once we get started here, once I go to this page and Steve gets up, Joe, why don't you take it over for us tonight?
All right. Well, Dr. Stephen Ice is a senior partner of Eye Care of the Valley, a 3-location optometry ophthalmology practice in Southeast Pennsylvania. He is currently the chair of the third-party Center Executive Committee of the American Optometric Association and a member of the Pennsylvania Optometric Association Third-Party Center. He is a past president of the Pennsylvania Optometric Association. Dr. Ice currently serves as a representative for the Medicare Carrier Advisory Committee for Pennsylvania and has served on the Pennsylvania Department of Health State Innovation Healthcare Model Work Group since 2013. So with it, it is my great pleasure and privilege, and your great pleasure and privilege, to see and hear Dr. Stephen Ice. Steve, take it away, please.
The only comment I want to make and add to that is Steve is a classmate of mine, 1995 graduate. So it's great to have you here, Steve. And, and Steve is the AOA third-party center. So for the AOA, the National Association, he's the chair for third party. He does a lot at that level, working with the insurance companies, division plans. And then Steve and I chair the POA committee, Pennsylvania Optometric Association, and I'm lucky enough to have Steve as a resource and serve as a member on that committee. So that was my comments. That was a very robust bio, Steve, but it's a pleasure to have you here as a friend. I'm turning off my camera, Steve. I'm going to turn off my microphone. I'll watch the chats. It's all yours.
All right. Thank you, Joe and Greg. And thank you, everyone, for being here tonight. Glad to spend a couple hours with you here going over some approach to billing and coding medically wise. And as Greg had alluded to, there are definitely some changes coming down the line starting in 2021. So we'll go over some of that and get you started in making some changes in your thought process to make that work well for you. First of all, my financial disclosure statement. I have no financial interest to disclose, and I will refer to some dollar amounts throughout the presentation. All the dollar amounts listed are Medicare values for Southeast Pennsylvania, which is where I practice. So obviously what I'm quoting will probably look a little different than what you may see, a little more, a little less in your areas across the country. And I'm in no way indicating that you should be charging these amounts for these services. These are just what Medicare has paying in that area and their set value. We'll start a little bit about talking integrating medical services into your practice. I've done this talk for a number of years, and every year I do it. I definitely see more and more optometrists who are much more comfortable doing medical optometry, billing medical optometry. So this little piece is become a little less necessary, but I know there's still some practices out there or some doctors who maybe haven't had a chance to practice in a situation where they're comfortable doing that. So, some of this gives you a little introduction and some thought process on how to, move that more into your practice. A lot of optometrists are concerned about, abandoning their roots, so to speak, by going into medical optometry. We've been doing eyeglasses, contact lenses, taking care of patients' vision for many years. But in no way does it mean that we're abandoning that part of our practice. What medical optometry lets us do is enhance our services to those patients, let them get higher levels of care at the same practice so they don't have to run around to different locations to get that. There's three things you want to consider when you're transitioning into medical care. One is, how much medical eye care am I comfortable with? If you're just transitioning into doing this, you don't have to do everything. You can pick the areas that you're comfortable with. I know that there's a lot of optometrists out there who specialize in certain areas of medical optometry. And there's some practices where they cover, almost like a general medical eye care, and then send things out when they're not comfortable with it. And you're definitely able to do that at whatever level you're comfortable with. What are your liabilities? Of course, generally speaking, if you're an optometrist, your medical malpractice is already taking into account what you're able to practice, not necessarily what you are practicing. But, obviously you do have to be maybe more available to your patients. You may have to have more after-hour calls, after-hour ability if problems come up. And again, that goes into how will this affect my current practice mode. You may have to schedule patients a little different, keep office spots open for patients who, may need to get in an emergency or have a problem that comes up with their medical care that you're taking care of. Then one of the biggest issues we have right now in optometry is dealing with vision or medical insurance. I hear this question quite a bit when I'm speaking. We do have a lot of overlapping carriers. Patients come in looking to use their vision insurance, but, we have a problem where we're dealing with something medically and we have to feel like we have to bill it to their medical insurance. Also, the use of CPT codes. Some of the vision plans require us to use certain CPT codes that maybe don't jive with the way the medical plans use them. And that kind of can create some confusion and make things a little difficult for us. We got the comprehensive medical eye exam versus the comprehensive vision benefit exam. And sometimes that can be a little hard for optometrists to, navigate because, we do eye exams, and for a lot of us, we feel like, what we're doing, time-wise and test-wise, there's really not a big difference there. But as we'll see as we talk later in this program a little bit, the medical decision making is really what makes the difference there, and what you're addressing in that exam, and having to get that justified in our own minds so we can express that to the patients, and make them understand why we're doing a medical eye exam for their diabetes as opposed to a vision benefit exam, through their routine vision when they are diabetic. We also have to deal with some point of service issues. The appointments, how do you appoint? Do you have to supply more time for those patients? And also co-pays, that's really a big thing. And that's where, sometimes you have patients who know that they have a lower copay for their vision benefit, but you're doing a medical eye exam for them and the copay can be higher or not what they're expecting, or there can be deductibles. So those are all things that we have to be able to navigate, when dealing with this medical vision dichotomy. So got a few little graphics here, one of the things when you're billing and when you're coding is you want to work smart. Sometimes we feel like this guy down in the bottom right-hand screen, where we're chopping away with a hand axe trying to get through the day, work through patients. And the key is we want to make sure that when we're doing this and when we're seeing patients that we're getting paid correctly. And really the key to getting paid correctly is using these codes and making sure we're billing and coding at the appropriate level to make sure we get reimbursed for what we're doing. We generally have two sets of codes that we can use for office visits for patients that come in. We're kind of unique with that in that, many specialties out there are only limited to the 99,000 codes, but we have the 92,000 ophthalmologic service codes, and we have the 99,000 E&M codes that we can choose. And, that gives us more choices, more options, for things that, what's most appropriate for the patient in that situation. And then we just have to weigh which is the better option. Okay, well, why would I worry? Why do you really worry about what level you code? Why can't I just pick a claim? When I first started practicing, I really didn't know too much about billing and coding. And, I remember when one of the doctors I started with, he had a little chart on the wall by the checkout desk and said, well, we charge this much for an eye exam and Medicare pays this much at that level, so we just bill that level. And that's how he coded. I learned pretty quickly later on that that's not the way to do it, and you could run into some real issues. And really, why would you worry? Medicare is using uses outside auditors to review claims. And I think most of you are aware of that. These auditors are paid contingency fees based on a percentage of the overpayments and underpayments they find. And now this slide that I have up here was from when I was doing this talk back in 2015. And at that time, when they first started doing this program, the prepayment, they also started doing some prepayment audits where they kind of looked at records before they paid them, and they found that it prevented $51 million in improper payments. And as this program went through its first year, they got the data, they found that the auditors found $2.39 billion in overpayments. Now that's Medicare Part A and Part B, hospitalization and office visits, but there was quite a bit of overpayments going on. They also found $173 million in underpayments. Believe it or not, they'll look at it and they'll let you know if you're undercoding a little bit too. But you can see the difference there. There's a huge difference, and Medicare found this to be a very, very successful program. So when 2016 rolled around and I was doing the same talk, I went through my system and went through my research, and I was looking for the same numbers to present. So basically, this is the same slide, but you can see that the prepayment audits actually prevented 4 times as amount in improper billings with the prepayments. So they really ramped up that. And now you see they only found $360 million in overpayments, along with 81 million in underpayments. So both of those went down, and we saw an 83% decrease. So, this program not only found the overpayments and returned that money to Medicare, but it also, deterred people from, or practices from overbilling. And, so of course Medicare sees that as a win too, whereas they're not getting as much overbilling issues happening. So we're going to go to our first polling question. I'm going to give you a little background on this first. I start this out simple billing question. I pulled this from a popular social media site that a lot of you probably look at. And I really kind of put this up to kind of just warn people that, there's a lot of places out there that you can get your billing and coding information. But just make sure you know where you're getting your information from. There's a lot of people who will give you their opinion on things, but you want to make sure that they have it coming from the source, from Medicare, from CMS, from CPT, that you're getting the correct information, and there's a lot of sources out there that are a little more reliable. So this poll actually popped up on a Facebook site. So I kind of want to just use this as an example to get us started. So you see, we have a simple billing question, which in my mind, there's really no simple billing question. But you see a new diabetic patient, you perform a comprehensive dilated exam, the exam is unremarkable, you send the PCP a letter and recommend seeing the patient back in 1 year. Do you bill a 99203 or a 92004? Then the poll actually included a 99204 as a third choice there too. So I think I can turn this over to Greg now, and he's going to actually run the poll, and you guys can choose based on what you have there, which I know isn't really enough to do a thorough coding job, but what would your answer be on that first question there, generally speaking, and knowing what you normally would document for that?
And I did launch the poll about a minute ago, Steve, and I'm going to get people some time to weigh in here and let you take a deep breath, because I know what it's like to be a single person lecturing, so you get to inhale, exhale there a little bit. But I also want to remind everyone that I did launch Dr. Ice's handouts. He's got a handout for this whole presentation, 6 slides per page. And it's a billing guide, I believe is what it is also, that he has shared with everyone for tonight. And I'm sure he'll go over that at some point. And also a reminder, in the chat area, right above where the polls are, where you can post questions, Dr. Saka and myself will police those as time goes on, and we'll ask Steve. Steve, with that being said, I think it's enough time for the poll. It's kind of slowed down here a little bit. 62% have said 92004. That was 61%, I think is what I said. 61%, 92004. 16%, 99204. And then 21% did 99203.
Okay. And actually, you'll see on the website or on the social media site, really similar kind of results. Definitely very heavily weighed toward the 92004. So what we're going to do now is we're going to kind of go over these codes, how you choose them, what their requirements are, and then you will revisit this question a little bit later in the program again. So as you all are aware, the 92,000 codes, or the general ophthalmologic codes, we have 4 options to choose from on those. We have 2 codes for established patients, and we have 2 codes for new patients. The comprehensive codes, the 92004 and the 92014, which are new and established, you can see up there with the little N and the E next to them. The requirements for these are pretty straightforward, pretty simple, and that's why a lot of doctors like to use them, optometrists and ophthalmology included. The requirements are you need a history, you need a medically appropriate history. For the comprehensives, you need an externals and motilities. You need a gross visual field, such as confrontation fields. You have to do some level of ophthalmoscopy, meaning you're looking into the back of the eye. Included in those 2 is you need a total of 9 elements of an eye exam, and you need a diagnostic and treatment plan. And intermediate is very similar. You need the history. With this, they want to see that you looked at the external and adnexia of the eyes, and you need 3 to 8 elements of the exam, along with the diagnostic and treatment plan. So real simple, here's the elements of an eye exam. We're all pretty good with this, but there's just a couple things on here to think about, when you're seeing it. The first thing is when you're bean counting for your number of elements of an eye exam, visual acuity, which is one of them, does not include a refraction acuity. As you're probably aware, and we'll touch on it a little bit, the refraction service is a separate billable procedure aside from the 92,000 code for the comprehensive eye exam. So any acuity obtained as part of the refraction is not counted as a visual acuity for the eye exam. So if you want to count one of those towards your exam credit, you have to do it entering visual acuity with or without glasses and have that in a separate spot in the exam. Again, gross visual fields are required for comprehensive, eyelids and adnexia are required for intermediate, ocular motility is required for comprehensive. You can see the other elements there. And then you need one of the last 2 for a comprehensive eye exam, either documenting the retina or the optic disc. This kind of just gives us a little general breakdown of what we commonly see in optometry practices. And this really kind of makes sense. As a general rule of thumb, most optometric practices are doing comprehensive eye exams. So you're going to see, 9204s, 92014s dominate. And generally speaking, we're going to see more established patients than new. So let's look at the definition of the ophthalmologic services, and this comes directly from CPT. Intermediate ophthalmological services describes an evaluation of a new or existing condition complicated with a new diagnostic or management problem, not necessarily relating to the primary diagnosis, including history, general medical observation, external ocular and adnexia examination, and other diagnostic procedures as indicated. And it may include the use of mydriasis for ophthalmoscopy. There we go. And the comprehensive ophthalmologic services describes a general evaluation of the complete visual system. The comprehensive service constitutes a single service entity, but need not be performed at one session. So with the 92,000, if you're doing a 92014, you could actually do that exam, bring the patient back on another day to finish some of the tests, such as the dilation, and you don't have to bill a second office visit. It can just be included as part of that first one. The service includes history, general medical observation, external and ophthalmoscopic examination, gross visual fields, and basic sensory motor examination. It often includes, as indicated, biomicroscopy, examination with cycloplegia or mydriasis, and tonometry. So this is one question we get a lot is, do you have to dilate a patient with a 92,000 code? And the way the definition is worded, it says it often includes as indicated. So technically you don't really have to dilate to do a comprehensive exam. But my comment on that is if you're doing an exam where you're examining the retina, or you're examining the posterior pole, the nerve, are you really able to do a thorough evaluation of that without dilating the pupils? So, generally speaking, there might be 1 or 2 cases, or especially a patient that has really large pupils that you can document it's not needed, but someone who's routinely doing a 92,000 code comprehensive and not dilating, I think you could be at a little bit of a risk there. The other thing to keep in mind is, and I talked about this a little earlier, is, a lot of vision plans require you to use like a 92,000 code to bill for their routine vision exam. So you're going to build a 92014 for a routine vision exam. In those cases, they're not using it as a medical visit as we are here. So what you do with a vision plan is different than what we're talking about here as the requirements for the medical visit. And that's where some of the confusion and stuff can come in at times. So remember, when I'm talking here about these 92,000 codes, I'm talking as using these codes for a medical visit to a medical insurance. The final piece, which is really important, is it always includes initiation of diagnostic and treatment programs. So, and they go on further to define initiation of diagnostic and treatment program includes the prescription of medication, arranging for special ophthalmologic diagnostic or treatment services, consultations, laboratory procedures, and radiological services. So again, here's where there's a little bit of a fly in the ointment with the 92,000 codes is really if you're not doing anything beyond the normal monitoring of problems, this code may not be appropriate and you could be at risk with some audits. And I'll kind of show you an example here. This is actually from a doctor's practice in Pennsylvania where they dealt with a audit, and this doctor's practice was dinged for quite a few 92014 codes, and you can actually, in this case it's good because you guys can actually probably read that little fine print at the top, but this is how the audit information comes. They give you this page with all these little things on there that you almost need a magnifying glass to read. But you can see right on there, it does say documentation does not meet the required elements for level of service 92014. No initiation of a diagnostic or treatment plan. The other interesting thing on there too is they also say documentation does not fully support the diagnosis of ocular hypertension. Pressure is soft, retinal exam shows no details, and CD ratio consistent by 3 exams. So a lot of times they can look at what you're documenting on there too, and just because you have a diagnosis, they can look in there and make sure that it makes sense with what you're presenting as your record. So you really have to make sure that the medical necessity is there for what you're doing. So basically this goes to show, let me see, I'm going to go back 1 second here. So let's spend a little time on this because I know I get a lot of questions with this, so I'm going to try to anticipate a few questions. One question I get is prescribing glasses constitute a diagnostic or treatment plan? And I would say generally no, and some of that does come back to the refraction issue. Again, a refraction, is a separately billable service, so the determination of glasses through a refraction technically isn't even really part of the medical visit that you're doing. That being said, if you have a patient that is undergoing, myopic shifts due to cataracts, or they have double vision and you're dealing with treating their double vision with glasses with prism, then I think that goes to a different level there. And I think you can definitely say that, prescribing those types of glasses are a treatment plan for that patient, especially because the glasses are keeping patients from having to undergo cataract surgery or maybe eye muscle surgery, to take care of their double vision. The other thing too, I get a lot of questions is, does it count, telling people to get, artificial tears over the counter? Again, by the definition that was presented there, it does say prescribing medication. So it doesn't really hit it. But I think if you're looking to use 92,000 codes a lot, you have to make sure that your plan is written in a manner that indicates that you're looking for a problem, you're looking for progression on the problem, or that there's at least some kind of risk to this patient that needs to be followed. So putting down that a patient's is a glaucoma, let's just say cataracts. Patient has cataracts. You're not doing anything monitor in 1 year. You're going to have a hard time, holding that up as a diagnostic or treatment plan under audit. If you were going to try to, put place you would have
Well, hold on one
yourself up
second,
with some
Steve,
issues.
because
Yep.
you're lagging. Joe, is he lagging on your end?
Yes.
Okay.
Okay.
Let's
Does
see,
does it seem any better now?
Yep, you're
Yes.
good now. So
Yes.
perfect.
Okay. Yeah, let me just check. I'll make sure that no one is messing with my bandwidth here. Okay. All right. While we took a break there for a second, Greg, did you see any questions pop?
No, everything was pretty quiet. Here's one here. Like I just scrolling through here. Just comments, just some housekeeping. But there is one here. It says, when do you decide to differentiate a 92 versus a 99 when billing for medical? And that might be still coming, but that's the only question that's out there. So.
Right. Yeah. And we're definitely going to get into that and do a few more examples. And this is one of the pieces that answers that question right there. You know, in my mind, if I don't have what I feel comfortable as a diagnostic or treatment plan for that patient, you know, if I'm not ordering tests, if I'm not writing a prescription for medication, if I'm not having them return in a fairly short period of time to monitor for change, you know, in my mind, I feel if I have them come back in 3 months to recheck something that's or less, that's probably good. If it's longer than that, then sometimes in that mind, okay, then in my mind, then that's maybe at a little bit of risk under audit there. So that's one of the first pieces right there. Another thing is right here is watch your diagnosis. These codes, I have written here, these codes may not qualify for comprehensive level. I have may not because prior to switching over to ICD-10, these diagnosis codes under Medicare by themselves on a claim with a 92004 or a 92014 would not pay. It would be downcoded to an intermediate automatically. With the switch over to ICD-10, I haven't been able to find the exact documentation that that's still the case, but my suspicion is that it is. So if you have a patient that comes in and their only problem is a general conjunctivitis, that there's no other further systemic issues that you're looking at, or, you know, they have a pterygium and that's their only medical issue there, but you want to look into the back of that eye and you want to get paid for a comprehensive level, then you may have to look to jump over to a 99,000 code because, you know, you may find that you're getting downcoded to an intermediate as opposed to a comprehensive.
Steve, there are a couple of questions coming in. Do you mind?
Nope, go right ahead. I prefer it that way.
One question is, I think I know the answer to this, but does OptoMap qualify as DFE?
It does not. The OptoMap is a separately billable procedure, and it's whether you're billing it as a screening or as an addition to the exam, or if you're doing it like as a fundus photo, that's actually a separate procedure. So that by itself would not check the box for a DFE in that case.
Another question is, so diagnosis of cataract and treatment plan to monitor in 1 year is not sufficient for a 92014?
Yep, and basically when you read that definition, I'll go back here a little bit, includes the initiation of a diagnostic and treatment plan. And the initiation of a diagnostic and treatment plan includes the prescription of medication, arranging for special ophthalmologic diagnostic or treatment services, consultations, laboratory procedures, and radiological services. So, we're not doing a special ophthalmologic diagnostic. You're not bringing them back to do, like glare testing or some other testing there, or you're not doing anything that would really be considered a treatment service. So I think you're really kind of at risk there under audit of running into an issue. And again, that's where the wording in your plan becomes very important, that you want to make sure that if you feel more comfortable billing that as a 92,000 code, that you're wording that plan in a way that you're bringing the patient back and looking to, for changes that would warrant, cataract surgery or something along those lines. And again, like I said, I always go to the source and read the definitions that are here that are from CPT. So again, don't shoot the messenger, but this is how the the definitions are written. And again, we have seen some examples where this can get audited this way and can get dinged. So again, you want to watch that and make sure that you feel comfortable that if you're under audit, that you can defend the fact that you have a diagnostic or treatment program. And again, a lot of it will depend on the auditor. You might get an auditor that takes that and feels comfortable with it. But if you get someone who's more aggressive, they can use these definitions against you and make it a little more difficult to fight it. All right. Any other questions right now, guys? Nope. Okay, not hearing any. Next, we'll talk a little bit about the refractive codes. I already alluded to some of this, and 92015 is the refraction. Again, that's a separate billable service that is not included in a 92014 or a 92004. So if you're doing a refraction on a patient, you definitely want to bill that as a separate billable procedure, and you can bill that. Generally, most medical plans won't cover that. Some do, but most don't. Medicare definitely doesn't. So again, that's something that you would have to collect from the patient directly, and that they would generally have to pay for. We also have the Comprehensive Ophthalmological Examination HCPCS codes, the SO620 and the SO621, one for new, one for established patients. And basically, these are a general comprehensive ophthalmologic exam, and these codes do include the refraction in them. So if you're using the S codes to bill an office visit, you don't have to add the refraction as a separate billable code on that. Okay, so I think we got our questions out of the way of the 92,000s for now. So I'm going to...
Steve, hold on 1 second.
Yep.
Tara asked, is it true that anytime you dilate a patient, one can bill a comprehensive?
For a 92,000 code, so long as you hit the elements of the exam, you can. Again, like I said, you need the number of exam elements. So long as you're doing enough other exam elements, I mean, if you bring a patient in, you throw drops in their eye and just look in the back of your eye, you're not going to have enough bean counting. But, generally speaking, when you have a patient come in and you dilate them, you're going to look at their anterior chamber. You're going to look at that. You're often going to do a pressure reading. So you should be able to get enough beans to go there. So I would say yes, but with a little bit of an amendment there saying so long as you're doing enough other elements of the exam to do that.
Steve, do you mind if I jump in for just 1 second?
Sure, please do.
Because I do the jurisprudence course for Florida, and we have what's called comprehensive vision analysis, which many would say is the comp exam. One of the things that's required in there is refraction and acuity. Mm-hmm. So while you were talking about what you're talking very, very eloquently and accurately about the insurance and Medicare billing guidelines, Florida can be sometimes a little bit quirky. So there's always that slight danger that if you write a comprehensive and anything ever goes before the Florida board, they may actually say, where's refraction and acuity? That's all. Mm-hmm. That's all I want to add.
Right. Yeah. And of course, state laws, state requirements, always, trump what you're doing with the insurance companies, and that's where it can get a little confusing too. And again, and I know when we do things in Pennsylvania, we're always looking to not allow, medical codes like CPT codes or ICD-10 codes have any place in determining what we do, for our scope of practice, because there can be definitely a disconnect there. Just something as simple as there's a lot of codes that we use that are defined by CPT as surgical codes, but obviously, in most states, we're not able to do surgery, and that could even cause an issue there. So yeah, that's a very good point, Joe. And you definitely want to look at your state laws to say, what do you have to do as part of that exam to keep the patient care to where it should be in your state, along with also meeting the requirements of your eye exam. But again, if you're doing that refraction and you have to do that refraction, you should be billing that refraction too. So you get paid for it also. Okay, so now let's dive into the E&M service, the 99,000 codes. Now, and part of the reason I do the 92,000 codes first is I often hear people say, oh, why just ignore the 99,000 codes because I'm just going to use the 92,000 codes. And then they don't really listen to what we're talking about. But as you can see with the 92,000s, there are some times where you may not be able to use them. And there may be some times where you may be better served using the 99,000 codes. So again, now we're going to go into how to determine those codes. With these codes, again, part of the reason that people shy away from them a little bit is you have 5 codes, new and established, for a total of 10 codes. You have to do a graded history, a graded exam, and a graded medical decision to determine the level of the code. So again, it can be a little bit more complicated, and if you're going to sit there and have to do that on every patient, it could feel very time consuming. So again, here's a little bit of a distribution of, generally how optometry practices bill these codes. And you can see, which surprises me a little bit, the 99213, again, these are for established patients. The level 3s tend to outdo the level 4s, which, in my practice, that's not the case. But I have a feeling because a lot of practices tend to use these just for shorter medical visits, that's why we see this distribution. And these distributions are a little bit important because I'm going to share with you an example here of, the insurance companies look at that. And here's one from Highmark Blue Shield, which is a carrier in our area in Pennsylvania. Obviously, I'm not deep into the Highmark area. Greg would have probably 10 times as many visits on his analysis as I do. Being in the eastern part of the state, we don't see as much. But you can see here that they sent out this letter, alerting me that I'm billing a lot higher rate of 99214s over 99213s compared to other, eye care providers. So insurance companies will look at that. They will look at that as something that, maybe they want to look at audit-wise. But that's why it's important for you to understand, what you're doing, what you're billing and coding. So if they do decide to come to you, you feel comfortable in defending what you've done. And generally in my office, this is what I want to see from my providers, because that means we're generally billing more correctly. I'm going to go over this briefly. This is my coding guide. And this is the one that I used currently today through 2020. As I kind of alluded already, everything is going to change a little bit in 2021. So I'm not going to spend a lot of time on this because we only really have 2 months of how this works. But I kind of created this coding guide, to use in the office. So, as a guide to kind of show what you need for the different levels. And, you have to get 2 out of the 3 components. And generally speaking, I usually spend some time going through this and kind of coming up with some easy answers to make it easy so you don't have to think about what you're coding on each patient. But I'm not going to spend really much time on that today. I'm going to go more into the changes for 2021s. But just to show you, this is how it works right now. You have to have a graded history where you need a chief complaint, history of present illnesses, status of chronic conditions, review of ocular systems, past social family history. There was a lot involved there in the history that you had to go through and make sure you were documenting. You had to do certain level elements of examination. And you also had to do a level of diagnosis, to hit those levels. And then what you did is you could circle the 3 boxes. If you got 2 out of 3 at the highest level that had 2 out of 3, that would be the level of your code. So again, and this is the same for new patients where you had to get all 3. So I'm going to kind of skip over this a little bit, and we're going to kind of go into the next polling question here, which is polling question number 2. And I'll turn this over to Greg, but how familiar are you with the updated E&M 99,000 codes guidelines for 2021?
Okay, Steve, it's published. And again, how familiar are you with the E&M 99,000 Office Visit Code Guidelines, the update that's coming? And you have 3% saying, I'm not sure if you can see it, Steve, so I'll read it.
I can't, yeah, thanks.
Okay. 3%, 2% saying very familiar with these updated guidelines that are coming for 2021. Somewhat familiar. And then you're famous. What you talking about, Willis?
Yep. That's
not much. That's why I'm here. 75%. So 75%, that's why they're here.
I want to know what's going on.
Somewhat familiar, and 2% very familiar. So there you go.
Okay, great. And Me and Greg had this discussion. You pretty much have to be probably 45 years or older to catch that reference. But okay, so basically what happened is back 2 years ago in 2018, Medicare proposed changing how they're paying for office visits for the 99,000 codes. And really their motivation for changing this, they said, was to reduce administrative burden and improve payment accuracies. So basically this is what they proposed. They wanted to allow practitioners to choose to document office visits using medical decision-making or time instead of applying the current, 3 levels of history, exam, and medical decision-making, or you could continue to do that if you wanted to. But they were looking to make it a little bit easier. And really what they wanted to do is they wanted to allow you to not maybe have to spend as much time just documenting, pieces of a history that really doesn't have any bearing on the visit that you're doing, but you want to get all those check marks because you want to make sure you get paid for the visit. They also expand current options by allowing practitioners to use time as the governing factor, regardless of whether counseling or coordination of care was the dominant part of the visit. They also wanted to expand options regarding the history of the exam, allow practitioners to focus their documentation on what has changed since the last visit, rather than redocumenting information just to show that you could get to your level. And then the last part, which I find kind of interesting, because I think a lot of people didn't kind of realize this little detail, was to allow practitioners to simply review and verify certain information in the medical record that is entered by ancillary staff or the beneficiary rather than re-entering it. So technically, by the letter of the law with Medicare, if you had a staff member putting the history in the record and you didn't go in and re-click all those pieces of the history, technically you weren't supposed to take credit for that. I don't know how they really would have policed that or dinged you on that, but in theory, that's what you were really supposed to be doing. So they were looking to do away with that. Again, all this kind of wasting time and people just doing things just to prop up their billing levels. So this is what they proposed again, it would have taken place in 2019, and what they were going to do is they were going to keep the level ones the same payment wise, but you can see on the right hand side there, they were going to pay the same dollar amount for a level 2, 3, 4, or 5, and it was going to be somewhere in the middle of what you would get paid for a level 2 versus what you get paid for a level 5. Obviously practices that were doing a lot of lower level visits, thought, oh, this looked kind of alluring. But, a lot of the specialists out there who were doing a lot of level 4, level 5 codes, you could see they would go from, for an established patient, go from $109 or $148 down to $93. So that really didn't look too good. So they got a lot of feedback on this when they posted the proposed rule. And then this is what they were actually going to do. They actually took the level 5 out and kept that the same, and then just lumped level 2 through 4. And then you can see they kind of, instead of going up and down, they went sideways. They decided we're going to do a special code if you have certain specialized or primary care so you could get more money. Then you could do more codes if you had to spend more time, and et cetera, et cetera. So it got really complicated. So, everyone involved kind of, there was a lot of negative feedback on this, and finally, the AMA and CPT kind of reached out to Medicare and just said, "Hey, listen, let's postpone this for a year. Let's see if we can do something at the coding level that makes more sense, that can kind of, accomplish what you're trying to do without really messing with these fee schedules and how you're paying different levels of codes." Because there's, as you can imagine, there's a lot of issues that could come up if you're, paying different level codes at all the same price. So here's what they're coming out with starting in 2021. They did come forward with, you can choose the E&M level visit based on either medical decision making or on time. So the revised code descriptors require a history and a physical exam performance only to the extent medically necessary and clinically appropriate. So the history and exam are no longer considered key components for level selection. So you still need to take a history. You still need to, get the information you need from the patient to take care of them. You have to do the elements of the exam that you need to do, to examine them and take care of their problem. But as far as it goes for choosing your code, we're not going to do the bean counting on the elements of the exam, or we're not going to have to do the bean counting. We're not going to have to do that review of systems anymore on every patient, where you have to make sure you do your history and then do a second review of systems to make sure you can, check the boxes for that review of systems. And again, this is now where, it's kind of interesting where, it says, oh, you have to do, if you do a dilated exam, will you automatically be at a comprehensive level? Well, with the E&M codes, that was never 100% given anyway. But with this now, what you do in the exam really isn't going to matter. It's really just going to either matter on time or medical decision making. So this is what CPT has proposed, and which is going to be adopted. So again, we throw away the history. We don't grade our history anymore. We throw away the exam. We don't grade the exam anymore, even though we are doing it and have to do it, medically appropriately. But now we have three areas in medical decision making that we have to look at, and you need 2 out of 3 elements for this medical decision making. So, and you can see there's 3 columns. The first column is number and complexity of problems addressed. The second is amount and/or complexity of data to be reviewed and analyzed. And the third is risk of complications and/or morbidity or mortality of patient management. So our first one is 99211. And you can notice that absent is 99201. As part of this proposal, 99201, a level 1 for a new patient, is gone. Really what happened is the definition of that code, really there wasn't really any significant difference from a level 1 and a level 2 in a new patient, because with a new patient, you're having to do a certain amount of elements anyway. So when they went just to the medical decision-making part of it, that code was deemed irrelevant. So now if you're going to do a new patient, you're pretty much going to be at a level 2 to start, no matter what. And you can see when the patient comes in, you're going to have straightforward medical decision-making for that level 2 code, whether it's new or established. And again, this is something that's a little different too. With a new and established patient, we usually saw a 1 level code difference if you were doing the same thing on a single patient. With this new guidelines, it's actually going to be the same whether they're new or established. So that's a little bit. So you can see for the straightforward or minor problem, and of self-limited or minor problem, they don't give us. They define that as a problem that runs a definitive and prescribed course, is transient in nature, and is not likely to permanently alter the health status. So again, things like a subconjunctival hemorrhage, a kind of a minor allergic conjunctivitis, something along those. When we get to elements of medical decision-making, minimal or, the amount of complexity of data to be reviewed or analyzed, minimal or none. So there's really nothing to analyze or look at with the patient, as far as testing or data. And there's a minimal risk of morbidity from additional diagnostic testing or treatment. So really, pretty much anyone that we come in and see in our office for a medical visit is going to at least hit that. So you're going to be at a level 2 pretty much for anything that has a problem that they're addressing. As you go down to a level 3, you can see for the number of complexity of problems, you either have to have 2 or more self-limited or minor problems, or 1 chronic stable illness, or 1 acute uncomplicated illness or injury. So again, with a stable chronic illness, they kind of define that as a problem with an expected duration of at least a year or until the patient's death. And that's not going to really have any major issues, and something that's pretty controlled. So, and they really define that as, like, for example, something that we think of in our all practice is a cataract patient. So if you have a patient that has cataracts, they're really not at any risk for progressing. They're not changing too much. You're not worried about cataract surgery at this point. That would definitely fall under 1 stable chronic illness. A patient who's a glaucoma suspect, or even patient that's got glaucoma, and if their glaucoma is controlled, you're hitting all your controlled numbers, you're going to hit that number right there pretty easily. Or 1 acute uncomplicated illness or injury, something along the lines of like a regular, conjunctivitis or something like that we see that comes in that doesn't have, secondary issues that you're looking to deal with. When it comes down to amount and complexity of data to be reviewed and analyzed, you can see this is where it gets a little bit more complicated. You have two categories that you have to meet at least one of the two categories. So for any combination of the two from the following, your review of prior external notes from each unique source, review of the results of each unique test, or ordering of each unique test. So, that's pretty straightforward when you read it. So if you're reviewing tests for a patient that you ordered, like a visual field, an OCT, each one of those tests counts as one little checkbox. If you order a visual field and an OCT, each of those counts as a little checkbox. So again, any glaucoma suspect that you're ordering your visual field and OCT testing, you're going to get two checkbox there, and you're going to get that checked off. Or the second option is assessment requiring independent historians. So that is defined by CPT as, a patient that you have to get someone else to give you the history. Like if the patient is dementia and you have to have a family member come in, if it's a young child and you need a parent to come in and give you the history. So anytime that you have to have an independent historian involved, that does get you a checkbox there. And then the third part, risk of complications and morbidity, is low risk of morbidity from additional diagnostic testing or treatment. Now, they did not provide definitions for minimal risk or low risk, but again, when you see where the moderate risk comes in, basically anything that falls below moderate risk is going to fall under the low risk of morbidity, if you're hitting the number of complexity and problems addressed. So I'm going to go into this a little more detail, so don't panic too much yet, but I kind of just want to go over to you all the definitions that they gave here. Now, when we get into level 4 and level 5, you can see these charts really explode a little bit. And I do have a little bit of a standardized, a little bit easier version of this that I created. I like to have my coding guide on one sheet of paper. So when Greg referred to the coding guide that we uploaded in with the handouts, that's actually an Excel spreadsheet of this kind of toned down a little so you can see it on one page. And then it will give you guys the opportunity to, if you want to download that, save it, and you can kind of customize it a little bit, to make it a little easier so you know what you're kind of looking for each level. But when you get to level 4, now you need a moderate level of everything. So with the problems, you have one or more chronic illness with exacerbation, progression, or side effects of treatment, or two or more chronic stable illnesses, such as, if a patient comes in with controlled diabetes and they're got, cataracts that are not progressing to surgery, that would cover you two or more chronic stable illnesses. One undiagnosed new problem with uncertain prognosis. And what that means, the reason they put undiagnosed in there is under the old system, if you had a patient that came in that was new, any problem you were dealing with was a new problem because you hadn't dealt with it before. So they kind of put that undiagnosed in there, meaning that it's got to be a new problem that the patient didn't know about or you didn't know about. Even if maybe it was diagnosed before, if you don't have it in the history or you don't know that it's there, then it's a new problem that you're dealing with. Just because you never knew about it before doesn't make it fall into this category. Or we got one acute illness with systemic symptoms, or one acute complicated injury. And again, I'm going to go through some examples, a little bit more of these, after we go through this. For the data, review, and test and documents, this gets a little bit more complicated. The two categories from the level 3 get combined into category 1 on this one. So you see we have any combination of 3 from the following: review of prior external notes from each unique source, review of the results of each unique test, ordering of each unique test, or assessment requiring an independent historian. Or category 2, which is independent interpretation of tests. So if you do an independent interpretation of a test performed by another physician or qualified healthcare professional that was not separately reported. So for example, if you needed a patient, let's just say, for example, you're an optometrist and you have a glaucoma patient, but you can't do an OCT in your office for some reason. So you send the patient out to get an OCT. They come back and you have to look and interpret that OCT to determine the care of that patient. Then that counts as a checkbox in this category 2. And you only need one of these 3 categories for a moderate medical decision making. Now, I notice they have in there that says not separately reported. So if you have a situation where you order that OCT and the other office is only doing the technical component, and then you actually look at that and you bill and report the professional component and interpret that, then technically you can't count that as an independent interpretation of tests because you're actually getting paid for that interpretation of a test as another billing unit. So that's what that separately reported means in there. And then the third category is discussion of management of tests or interpretation with an external physician or other qualified healthcare professional or appropriate source, not separately reported. So if you have this discussion and you're able to bill that, as another visit in and of itself, then obviously you can't use that to check the box for category 3 on the visit that you're doing on this day. And then the third piece is moderate risk of morbidity from additional diagnostic testing or treatment. And they give a few examples on that. They didn't give a real good definition of it, but they gave some examples. So your examples are prescription drug management, decision regarding minor surgery, decision regarding elective major surgery, or diagnosis or treatment significantly limited by social determinants of health. So what that piece means that if you have a patient that has maybe some kind of mental issues or some kind of social economic issues where you would normally talk about treating them with a prescription drug, or you would talk about maybe looking into some minor surgery, but those determinants of their health will prevent them from actually even thinking about doing any of those things. You can document that patient would, require this, but is not able to go that route due to whatever reason. Then you could still use that to meet this level of risk, even though you're not really acting on it for that patient. Little confusing, but it kind of gives you some flexibility there just because you can't actually prescribe the drug or you can't actually order the surgery for those patients. And then when we get down to a level 5, we have the high levels. Again, generally speaking, you're going to be looking at things where the wheels are coming off the bus on these patients. You have one or more chronic illness with severe exacerbation, progression, or side effects of treatment, or one acute chronic illness or injury that poses a threat to life or bodily function. So again, the first example there, one or more chronic illness with severe exacerbation, side effects of treatment, there if you have a patient that, maybe you're watching them on Plaquenil treatment and all of a sudden you see some retinal changes due to the Plaquenil treatment, that definitely could probably fall under that high category there. Or obviously a patient comes in with an acute retinal detachment, papilledema, where you're worried about a threat, to their life and have to get them immediate urgent care. Any of those kind of problems that you're dealing with would definitely fall into this category. The data and test documentation is actually exactly the same as for a level 4, except you need to do 2 of the categories instead of just 1. So I won't go back through all those specifics again, but you just have to check 2 boxes instead of just 1. And then the high risk of morbidity from additional testing. So again, drug therapy requiring intensive monitoring for toxicity, a decision with elective major surgery, emergency surgery, decision regarding hospitalization, decision not to resuscitate, which hopefully we're not making those types of decisions in our practices. But again, here with the level 5, you're talking, a patient with major acute problem that has to be dealt with initially, or we're worried about them possibly losing their life or losing their function of their eye. And again, just to reiterate, when you're figuring this out, you need 2 of the 3 elements here. So you don't have to hit all 3 of these to get to that level. You just need 2 of the 3. Okay, and then I'm going to go into time a little bit, and then I'm going to do some examples, and then we'll do some questions, because I'm hoping my examples will maybe answer some of the questions. So if you don't want to get into all of the elements using the medical decision making, or if you're in a practice where you do spend a lot of time, evaluating a patient, maybe, like in a low vision patient situation where you're maybe not doing a lot of testing or diagnosing of problems, but you're actually working with dealing with the problems that they have. You can use just time, as an element to determine the code. And as we said, for 2020 and back, more than 50% of that time has to be coordination of care, or counseling for the patient. So the time that you use for an eye exam, doing the exam wouldn't count. That is now gone, and it's basically any time you spend examining the patient, coordinating care, speaking to another caretaker about them, reviewing records prior to the visit, going over records after the visit on that same day. All that can be used to determine the time for that patient. And what they did is they gave specific ranges for where the time falls. So you can see here, I'll say for a 99203, you're going to fall, if that visit falls into a 30-minute to 44-minute range, then you're going to be able to bill a 99203. If it's an established patient and that visit falls into a 20 to 29-minute period, then you'll be able to bill a 99213. Again, before this, most of my comprehensive visits were, in a 99214 range, and there you would have to spend about 30 to 39 minutes with the patient, in direct care, and doing those other things, which I would say probably most of my patients, I'm probably not spending quite that amount of time. So for me personally, I don't know that time is going to be a real benefit for me. And, again, you're going to have to do some real rigorous documentation of time. You have to document when you're going in the room with the patient, when you leave the room with the patient, and you definitely have to document any time that you're spending, reviewing records, coordination of care, speaking with other healthcare providers. Another little fly in the ointment is when time is used to select the appropriate level for E&M service codes, time is defined by the service descriptors. The E&M services for which these guidelines apply require a face-to-face encounter with the physician or other qualified healthcare professional. For office or other outpatient services, if the physician's or other qualified healthcare professionals' time is spent in supervision of clinical staff who perform the face-to-face services of the encounter, use 99211. So again, when they're calculating this time, they're talking about require face-to-face encounter with the physician or the qualified healthcare professional. So there's going to be a real question here as the time that your tech is, if you use a tech and your tech is working up the patient, it doesn't appear from the definition that you're going to be able to count that time towards the patient care. So that's further going to maybe limit the availability or the use of time to get to the levels where you're used to getting to or what you're comfortable with. Okay, I'll keep going here and then we'll do some questions. So they also have a code for prolonged services. It's 99XXX. This one is a little bit of a confusing one because a lot of times we'll use 99XXX as a general term for a wide range of codes. Now they actually have a code that's 99XXX. And what this code is if you see a patient beyond the limits of the level 5s, which you can see here are 60 to 74 minutes for a new patient and 45 to 54 minutes for an established patient, you can then actually add units of 99XXX for each 15 minutes of care spent with the patient beyond those time limits. So those you can use. And again, the prolonged services of less than 15 minutes should not be recorded. It allows for face-to-face and non-face-to-face care on the date of the encounter, meaning that if you're, again, providing care, you're speaking to, other caregivers for the patient, other healthcare providers, on the phone, talking to family members, coordinating care, all that can be used as part of the prolonged services. And then for those of you who are used to using prolonged services, you do not use 99354 or 99358 for time on the date of the encounter. You just use the 99XXX. So as a sample for this, a patient encounter has a duration of 80 minutes. So you have a patient that's in your office, your care, you're speaking on the phone, maybe you have a lot of stuff that you have to deal with that patient with other providers. And on that day of the service, you spend 80 minutes with that patient at total care. So again, if it's a new patient, you would bill a 99205, which is 60 to 74 minutes. Now that 74 minutes still falls short of our 80. So then you would add 1 unit of 99XXX, and that would take you from 75 to 89 minutes. That 80 minutes falls right in the middle there, so you're good billing that. For that same 80 minutes, if it's an established patient, again, you'd bill the 99215, which is 40 minutes to 54 minutes. And then you would add 1 unit of 99XXX, which would take you to 55 to 69 minutes. Again, that still falls short. So then you bill a second unit of 99XXX to get you up to the 70 to 84 range. So, okay. So, and again, now on this right here is my, the coding guide that I loaded in. I kind of removed some of the details out of there, made it a little more straightforward. And my goal on this is to hopefully make this even simpler once we kind of get into using it and get a little more guidance from Medicare on what they're looking for. But you can see I kind of basically took what we just went over and kind of made it a little smaller, made it fit onto one page between these two. It's not one page on the slides, but it is one page between this one and this one on an Excel spreadsheet that you can put on an 8x10 piece of paper and keep it in your exam room.
And Steve, I just want to remind everyone where that is, to give you a little time to take a breather there. So everyone that's on the webinar, if you shrink it down using those three little dots in the red rectangle there, if you go down to files, you'll see that there's a little orange dot there. And then when you open that up, you'll see two. I'm going to click on it myself. You'll see one that says Steve's Coding Guideline 2021 and Steve's handout. So all that's in there. And then put questions in the chat box. Steve, I saw you take a little swig there of water, yep. So pick it back up.
Okay, so let's do a couple like little examples here just to kind of run you through this a little bit. So I kind of split my screen here, my coding guide to have you show the 203s and the 204s, just because probably most of us live in the level 3 to level 4 range with most of our visits, and that's the decision you have to make. That's going to be a little more difficult. So let's start with an example here. Say we have a patient that comes in with a conjunctivitis, just a regular conjunctivitis, with, nothing that you're worried about systemically or have to do any further testing, just looks like a little bit of a bacterial conjunctivitis. So that patient, you're going to write a prescription for, you're going to put them on whatever your antibiotic of choice is, ofloxacin or tobramycin or whatever works best in your area and works best for the patient. So now we have two choices here. You can see we have the self-limited problem. We have the level 3 in the problem, but we have a level 4 in the risk of morbidity, or the moderate risk of morbidity. So now the question becomes, where are we going to end up with this is going to be determined by the third column in the middle, tests and documents. Well, really, with that patient, we're not ordering any labs. We're not going to do anything further. So again, we're not going to have that box filled. It's probably going to be down in level 2 because there's really nothing to do. So our second box falls into a level 3. So again, probably kind of similar with what you would see, when you were seeing a patient, in your practice now with the current guidelines, you'd probably be at around a level 3 for that patient anyway. So that really doesn't seem too much different. Again, one acute problem that comes in like a conjunctivitis. Now, let's just say that same patient comes in with a conjunctivitis, but maybe they have shingles. Maybe it's associated with shingles. The patient comes in, they have a red eye, you notice some little pustules on their forehead, and you're like, oh, are you getting any kind of pain, any kind of, back pain? And they say, yeah, I think I might be starting with shingles. Well, here now we have an acute illness with systemic symptoms, or say we have a patient that comes in with a uveitis, and there's maybe some further systemic issues that you're concerned about, or they have some further complaints. Well, then now you're down to a level 4 with that one acute illness with systemic symptoms. So now you can definitely push that up to a level 4. So again, here we're making a decision based on level 3 or level 4, and what you did in the exam makes no difference. What you did in the history makes no difference. So long as you did what you need medically necessary for that patient, you could do every eye exam test in the book, and if it's that first one example that we had with just the uncomplicated conjunctivitis, you're going to be at a level 3. But if you can push it up to that next box, then it could be a level 4. So again, this is going to be kind of a whole different way of kind of thinking about how we code things. And I know this is going to take people a while, and it's going to be a little hard to digest. But again, that's why I kind of like having this coding guide that you can kind of stick on the wall, and you can just say, well, if I'm prescribing drugs, do I fall in box 1 or 2? And you can make a quick decision on, can I build this a level 4 or should it stay a level 3?
So, Steve, I work in an area where right down the road from me is a rheumatology practice, and I get a bunch of red eyes coming in, usually linked to Sjogren's, rheumatoid arthritis, mixed connective tissue disease, and we can sit and rattle off the over 200 diagnoses that can be found in rheumatology. That acute problem linked with a rheumatologic, would that raise me, I guess, or not drop me, raise me to a level 4? Does that sound?
Yeah, drop you on a chart or raise you to level 4. Yeah. Yes. Yeah, exactly. And the thing you may run into there too, like you may end up doing some test results, reviewing some test results. If they send over some test results, you may look at some of that. But like I said, your acute illness, when you look at level 3, it's a chronic stable illness or an acute uncomplicated injury or illness. And like you said, when you start introducing those extra layers into it, in my mind, that pushes you up to a level 4. So yes, I would agree with what you're saying there.
Yeah. And the other one that comes in a lot of time is that, that red eye from thyroid eye disease, it's thyroid related. So I guess that would be a level 4 too. All right, good.
Yeah.
And all those years of history, exam, decision-making. Wow. That's out the door. Geez.
Yeah, exactly. Cause you would, it's a little bit of a double-edged sword, because with the old system, you could do a real comprehensive history and you could do a real comprehensive exam. And if it was an established patient, you actually didn't have to worry about this medical decision making. You knew you could get to a level 4 pretty easily. Now it's totally flipped over on us. And now you have to kind of pay attention to what the diagnosis problems are.
And I kind of like that you kind of put that drug management there and highlighted that right off the bat, because it just drives me crazy. I do a lot of chart auditing and I see optometrists out there. I lecture and I always say, there's Jewish guilt, there's Christian guilt, but what supersedes it all is optometric guilt. And, I do these chart audits and, they're prescribing Toberdex for marginal ulcers and, they're treating abrasions and putting bandage contact lenses in, and they bill level 2s. And it just drives me crazy because, we work hard to get these privileges. The state associations worked hard to do this, and then we, devalue our service. So that's kind of cool that, prescribing a topical medication as a drug management, boom, 4. Well, if it's a little bit less than that, at least it's a 3. It will hopefully get our colleagues away from those level 2s. So.
Yeah, exactly. And that's what we come back to is, making sure you're getting paid for what you're doing, and having this information makes you confident in what you're billing, that you feel comfortable billing those slightly higher levels, if you're on the fence.
Well, I want to say thank you for sharing this guide. So thank you.
Anytime. That's what I like doing, trying to make it a little more simpler for us. And I'm hoping in another 12 months, I'll have it even simpler, but it's just going to take a little time to get there. Okay. And I'll do a couple more examples here. Now, let's say we have a patient that comes in, I kind of alluded to this earlier, where they have 2 chronic stable illnesses, kind of like, they're a diabetic and then they also have cataracts, and that they have these problems, or they know that they have these problems. So you can see, though, just having more than one stable chronic illness gets you up to a level 4 right there, as far as that box goes. But of course, with those 2 patients, say you do your exam, there's no diabetic retinopathy. The cataracts are, pretty normal, 20, 25 cataracts, nothing that's really impacting the patient. So now we have kind of the opposite of the last one box in level 4, but our risk of morbidity is down on a level 3. So here, again, with no extra testing, like if we're not ordering any tests for the patient, if we're not doing anything in addition to determine what's going on, now we're looking at a level 3. But if we make a decision on that patient to get cataract surgery, say their cataracts do progress and they get to the level of having to do surgery, now we're looking at, getting to that level 4, once we make that extra decision on going beyond I'm just going to monitor this. All right. So, and actually the CPT and the AMA actually has a nice little website where you can go and read more information on this, because again, you can see there, for simplifying it, they made it quite complicated. And there's a lot to digest there. There's a lot to think about. So, on this website here, They have a lot of information. They have a lot more involved definitions. I didn't want to spend a lot of time going through all the definitions because that would pretty much eat up most of our time tonight. So if you want a little more information, you can go there. I'll also put a little plug in for the AOA. They've been doing webinars on this. So if you're an AOA member, you can access their recorded webinars where they go into a lot more detail on the definitions and on what's involved with this. So they actually did 1 hour on what I just did, and then they do it an hour. They're going to be doing an hour in a couple days on just the time element and how to determine the time element. So there's going to be a lot of detail there. So if you're really into all the details, definitely look that up. If you're not an AOA member, become one, join one, and take advantage of those kind of membership benefits because they really break it down and put a lot into it. So, okay, before we get into the payout here, are there any questions on there that you guys want to bring up to me? Because I know there was a lot there.
Yeah, there actually are. One that came up a couple times was, does the time it takes to dilate count as time spent with the patient?
If you're sitting there talking about their care, coordinating their care, talking about what you're going to be doing for them or what treatment they may need, yes. If you leave the room and walk out of the room and you're not in the room with the patient, then the answer is no.
Another billing question. Somebody took over an existing practice, but with a new and separate tax ID number. Are all patients considered new or established?
Yeah, if you took over the practice, probably technically, if it's a new tax ID number, you could probably get away with billing new for those patients. I would be a little hesitant because I'd be a little careful because, again, you have all the documentation, you have all the prior records. In my mind, I would probably play it safe and bill them as established. And what you're going to see is, I think you're going to see that the difference between new and established is going to become a little less prevalent going forward. So I don't think it's going to be as big of an issue. But I think by the letter of the law, you're probably okay on that because of the different tax ID number. I don't think they'll catch it in their system. But if they audit it and say, hey, you had all these records and you had access to all this prior information, we don't consider that new, then you might have an issue there. So personally, I would probably play it conservative and consider them established.
Steve, if fitting a medically necessary contact lens and it takes 54 minutes, can 99215 be billed?
I would say no, because the fitting of a medically necessary contact lens is actually a different code. The fitting of contact lenses is 9213. There's a series of codes, 92135, I believe, along that range, 12934. So actually, the correct codes for those would be actually the fitting of the scleral lens, at that point.
Another question comes up. The person said they're taught Medicare is generally better to use 9.2, and with other carriers go with 9.9. Is this good to use as a guideline?
I'll answer that one in a minute. So I'll postpone till I talk about the payout here, and I'll answer that one when I get to the end of that.
All right. Would flashing and floaters to rule out retinal detachment be considered level 4?
Again, it depends on what the diagnosis is. If your diagnosis is an acute PVD, and that's the only problem, that would make it be one acute. Let me back up here a second. So that would be one acute problem. So one acute, that one's right on the borderline, because if it's just a basic PVD and you don't see any other issues, you're not going to bring them back for any other follow-up. That might fall up in there under the one acute uncomplicated injury or illness. If there's anything associated with it that makes it more complicated, such as, you see any retinal traction, I would think if there's continued flashing, I would call that complicated because that increases the risk. So I would say in that case, I would consider it a level 4 if there's something a little more there. But if it's just a basic PVD and the flashes are gone, the floater's settling down, and you're not going to really see that patient back in any kind of shorter period of time, then I would say it's probably a level 3.
Would you have to have a systemic disease as your actual diagnosis for a level 4, such as rheumatoid arthritis or Sjogren's?
To get a level 4? No. So if you have an acute illness with systemic symptoms, you don't actually have to make the diagnosis on that. So long as there's enough of a systemic association there that you have concerns about that, then you should be fine, and you document that in the record.
Okay. So why don't you take over, and we'll come back to some more questions if we have time.
Sounds good. Okay. So let's talk about the payout a little bit, because that's where some of the decision making comes into choosing the code. So right now in Southeast Pennsylvania, this is what we're getting paid from Medicare for the 92,000 codes. This is what we're getting paid for the 99,000 codes. So I'm going to go through this kind of quick, but you can see if you have an intermediate exam like the conjunctivitis we talked about, if you're using a 92,000 code and you're treating that patient with medication, you're definitely eligible to use that level 2 code. Generally speaking, in today's world, that a level 3 would be the equivalent of that. So you can see there the 95 versus the 80 is a little better with the 92. Same for a level 4. You have a 135 versus a 116 on the 99,000 code. So that's where it comes in with Medicare. Generally speaking, if you're treating a patient, you're initiating a diagnostic and treatment plan, in today's world, you're better off generally using the 92,000 codes for Medicare. With other carriers, it can be variable, and I'm going to get to that in a second. Let's go to here. With a new patient, again, a comprehensive exam is generally going to be a level 3 with today's world, and you can see that matches the level 4 if I go backspace. There we go. A level 4 with an established patient is essentially the same as a level 3 with a new patient. So that's where there was that little disconnect with the levels. But if you can do a 92004, you can see that's like a $45 difference on that office visit. So yes, with Medicare, if you can use those 92,000s, you go ahead and use the 92,000s. But what to expect in 2021, this may be a little different. So right now, with the proposed rule, the conversion factor for the visits, the office visits, would decrease down 11% for $32.206. So what that means is specialties that do not generally bill E&M visits, the office outpatient ones, would experience the greatest decreases, while specialties and practices that bill higher level established patient visits would see the greatest increases as those codes were revalued higher to the rest of the E&M code. So in a nutshell, what happened with these changes in how the coding is and how the levels are, the RUC, which is the Relative Value Update Committee, they determine what goes into an office visit and what its value is. And then Medicare applies their conversion factor to all these things because they have to make sure everything is budget neutral. So if some codes go up, that means somewhere some codes have to go down. So what we're seeing is E&M established patient visits, like level 4s and level 5s, are going to go up. And then we don't know what's going to happen quite yet with other visits, but things like the 92,000 codes may go down. So we're going to have to watch that. So when you talk about other payers and what codes are best to use, you really have to look at your EOBs. So that's my next slide here. Look at your explanation of benefits that you get from your carriers, or look at the fee schedules. But I like to look at the EOBs because sometimes they don't always match what the fee schedules are, and you get a little better picture here. So this is an example from some unnamed carrier down in Southeast Pennsylvania. And these are two claims that are on the same plan for different patients back in 2014. But I check this every year. Nothing's changed, so I don't have to change my slide. But you can see on the top here, they paid a 99214. They paid $79.85. That includes the patient copay, everything. That's the total payment on that visit. On the 92014 down below, they paid $49. So, there are some plans out there that actually discount 92,000 codes because they consider the my codes, discount them lower. So you really have to pay attention what you're getting paid. So again, I always say, pull out your EOBs, look at what's getting billed. You may see discrepancies where certain plans, it makes sense to do that. I found with one Blue Cross Blue Shield plan that we use in our area, we were finding years ago that if we billed a 92 code, it was going to the patient's deductible, and we were getting things about that. And I asked the patient, I said, well, if you go to your if you go to your other specialist, does that get paid? And they said yes. So I'm like, So we tried billing that plan 99,000 codes, and ta-da, we got paid. So depending on the different plans, certain codes could go to deductible where others don't. So again, that's something that it's always best to look at what you're getting paid, through the carriers, and that'll help make a decision on which payers are best to use which codes for. And to say that all others other than Medicare are better with 99, every regional carrier is different, and I have doctors in New Jersey, which is right across the river from us, that they get paid differently by some payers than we get paid in Pennsylvania, and there's a difference there. So it can be very geographical. I'll go over a couple quick things here that have changed in 2020 that you may have already heard of. Codes 92225 and 92226 have been deleted. Those are the extended ophthalmoscopy, and they've been replaced with 99201 and 92202. 92201 is ophthalmoscopy extended with retinal drawing and scleral depression of peripheral retinal disease with interpretation and report. And the last part's important here, unilateral or bilateral. So before, when you were using the 92225 or the 92226, you would do a right eye or left eye, or you would code each one and do a right eye and a left eye, and you could get paid 2 for 1. With this, it's due to get paid for 1. So that was a change. And you notice that it also does say with scleral depression. So if you're using 92201, you have to document that you scleral depressed the lesion that you're looking for. For 92202, they have ophthalmoscopy extended with drawing of optic nerve or macula for glaucoma, macular pathology tumor with interpretation or report unilateral or bilateral. Unfortunately, they didn't put scleral depression on this one, because I'd like to see everyone try to scleral depress back in the macula or the nerve on patients. I think that would be pretty brutal. But again, this is the one that you would use for posterior segment of the eye. Again, you don't have to do scleral depression on that, and it gives you a separate code. So in theory, you could actually do extended ophthalmoscopy of the posterior pole and extended ophthalmoscopy of the peripheral retina at the same time and get paid for both. Another thing that changed during 2020 is 99072. That's a code that's defined as additional supplies, materials, and clinical staff time over and above those usually included in an office visit or another non-facility service when performed during a public health emergency as defined by law due to respiratory transmitted infectious disease. So many of you probably have heard this, that that CPT came out with this code about within the last 2 months. At this point, it's really questionable as to what payers are paying it. I've heard anecdotally that some people are getting paid. I've heard mostly that nobody's getting paid on it. Again, there's no fee set for Medicare, and they don't have a policy on paying it quite yet at this point. So it's something that we do have available to us, especially if you're in an area where you're having to do a lot above and beyond, with your patients and with your office to disinfect and make it safe for them during this time. The one thing that you do have to watch is if you do decide to use this, it has to be done universally. You can't just say, oh, I'm going to bill, Medicare and Aetna for this and not bill any of the other carriers, or I'm not going to bill my cash payment pay patients for it. You have to have a policy in place, and it has to be, universal for all patients across the board. And the other thing too is, you have to come up with a fee. Just randomly picking a fee could be an issue. So if you're going to bill X dollars for this code, make sure you've done some kind of documentation. You have something to determine why you feel what you're billing is a reasonable dollar amount. Okay. Real quick, the other thing that we're seeing a lot of changes, with the billing that goes hand in hand with this is everything's moving towards, medical decision making, and it's moving towards, quality of care. So, we know PQRS, we know meaningful use. We've seen things change to ICD-10. We know that, you have to, some of what you get paid can be dictated on what level of ICD-10 code you use. Like, for example, for glaucoma, we've seen payers try to do that. Clinical registries are getting bigger. AOA has one called MORE that optometry can go with. And obviously MIPS has replaced meaningful use and PQRS. And it's really important that optometry kind of, participates in that. I mean, you don't have to be perfect at it. You don't have to do a perfect job on it, but I think it's something you really should start integrating into your practice, because as we go forward and payers and Medicare are grading providers on their quality of care and what care they give, that can make a difference not only in what you get paid, also what patients you're allowed to participate with. And we don't want to be closed out of those patients. So, make an effort to start, participating in some of these programs, so they can see that optometry is part of it and optometry is a quality provider, for these patients.
Steve, I'm going to weigh in on that just a little bit before you do that case, let you take a breath there.
Yep.
Being the third party chair for Pennsylvania and kind of lecturing in this arena, not to the level that you do, but meeting with the payers. As you know, we meet with UPMC, Highmark, Medicare, and the list goes on. We probably meet with 5 or 6 payers. And, we went to school and, we focused a lot on evidence-based medicine. And evidence-based medicine is certainly how we want to, drive what we do in our practice. But I can tell you right now, ladies and gentlemen out there, that the hospitals and the payers that are out there, they want to know when you use this evidence-based medicine, how does it drive the outcome? So when I go and talk to these payers, they don't really want to hear, oh, yeah, optometry is using evidence-based medicine. They're like, okay, thanks for doing something that was years ago. How are the outcomes? And that's when Dr. Ice is talking about registries and participating, that we want to be a part of registries so that they can pull data from our electronic health records and see that seeing a diabetic and monitoring them closely and asking about their hemoglobin A1C, are you putting that into your record? And then they pull it and you follow it. Does that help them with their outcome of vision loss or maybe losing limbs and neuropathy and so on and so forth? So that's where you hear outcome-based medicine now, and that's why it's important to participate in these different activities that are out there. Okay, Steve, all yours.
Right. Thanks for the input there, Greg. And yes, it's, we work with this stuff all the time, trying to raise optometry in the eyes of the payers, patients in the world. And this is all important stuff. Okay, let's do a couple of quick cases here just to do a few more examples of how these codes work. So case 1, I have a 26-year-old woman presents for an examination. She has a history of optic nerve drusen, no visual complaints. When we do her exam, we have her findings. She's myopic. No RX change, vision is 20/20. We look at the optic nerve drusen and, it looks standard. Nothing seems to be changing. So right there, under the current system, I'd probably bill a 99214. Pretend there's not a picture there, that I didn't order photos or I didn't order any other testing, so without a diagnostic or treatment plan, monitoring yearly, actually we're giving her contacts because that was really the main crux of why she felt she was there. But we do monitor this yearly. So 99214. Now in today's world with the coding, it probably would be a 99, or if she was a new patient, we would be a 99203. I'm sorry, I got ahead of myself there a little bit. So again, with the old system of a new patient is a level lower than what an established patient was. So now the same patient comes in, same thing, no visual complaints, nothing else. But when we look in the back of the eye, you can see down there to the lower left part of the nerve, you can see there's a little bit of a hemorrhage there, adjacent to the drusen. So, this changes the game a little bit. So now we're obviously going to take pictures of that, which I did. And, now my code flips from a 99,000 to a 92,000 because we did photos. And assuming it was Medicare, which obviously it wasn't because she's 26, but assuming the same payment levels, we flipped to a 92014, got paid a little bit more. Plus we billed for the fundus photos. And then obviously I had her come back, and we were having her come back for some other testing. So let's just go through this and code this with the new system right now and see where we're at. So here we have one undiagnosed new problem with uncertain prognosis. So I would say even though the optic nerve drusen is an established problem, the retinal hemorrhage or the nerve hemorrhage is an undiagnosed new problem. So I think we would be good there with a level 4. Or we could call it one chronic illness with exacerbation progression, because she had the chronic illness, but something changed there. So we have some progression. Here we ordered photos. We ordered a visual field, which she's going to come back and do. And I reviewed the photos that day in the office just to look at that. So we have, as you can see up above, we must meet one of three categories below. Review prior external notes, no. Review and results of each unique test. So I reviewed one test, so that would be the review photos. And then the ordering of each unique test. So I ordered photos and I ordered visual field. So in my mind, from the way this reads, I hit 3 for that. So I think I'm fine with this for that level. Because where it becomes a little dicey is in this moderate risk of morbidity. It doesn't fit their perfect examples of, drug management, decision regarding minor surgery, decision regarding surgery. But I still think I would call this a moderate risk because, when you throw that hemorrhage in there with optic nerve drusen, the outcome's a little more questionable. So I think you could also say you're at this level for the moderate risk. But the good news is because we only need 2 of 3, we were able to hit it with the testing levels, and we're good with that. So patient comes back in 2 weeks, and we did the visual field, and we dilated her again. So again here, when we looked at this, it didn't really look any different in 2 weeks, but the visual field was perfectly clear. I had actually spoke with our local neuro-ophthalmologist about it, and he felt like she was in good shape with not having to do anything further. So again, here we could build this at 92014 because I'm still going to have her come back in a few weeks and check for any more progression, make sure that she's resolving, maybe a few weeks, maybe even a month or so, depending. I forget exactly which we did at that point, but we did do the visual field and we can bill for that also. So just for an example with this patient here, just with what we had come up here with the billings, this patient that, basically was coming in for her yearly monitor of drusen, but also for a contact lens exam, medical billing, we ended up with $388.62 of visits, tests, everything else. And this is a case here where we can definitely manage this in our practices. It's something we can handle. You may want to consult, verbally with an ophthalmologist if you're a little unsure, but you don't necessarily have to kick this out the door and let another practitioner do all the tests and take care of all this for the patient. This is stuff that medically we can do in our practice and take advantage of. So again, for this next visit,
I was going to make a comment, Steve. You can also, get on my soapbox, as you know, we can also consult with another optometrist too.
Absolutely.
As opposed to an ophthalmologist.
Absolutely, yes. Then for this visit here, again, we still have the one chronic illness with exacerbation, progression, or side effect of treatment. Here we reviewed the visual field, but we really didn't do ordering any new tests. We didn't review any other tests. So we actually didn't even get to the 2 on this middle one here. So now the question becomes, where are we with the risk of morbidity? Again, this one's a little unclear from the charts we have. You can see the top one says low risk of morbidity from additional testing or treatment. I think, definitely we're there. The question is if I still feel like I have to bring the patient back within a couple months to monitor for changes or treatment, I think I'm comfortable doing that. I think I'm comfortable still doing a level 4 on that one. But that's one that kind of falls right in the middle there. And hopefully we'll get a little more guidance with that from CMS and from, CPT. And the one thing that I really like to do, and in my old lecture before all these new things came out, was I actually went over an audit guide. Because what you'll find is on Medicare's website, on your local Medicare carrier, they will have an audit guide to go through and show you what auditors use to audit your records. So hopefully we'll have an audit guide for this version of the 99,000 codes. And once we have that audit guide, that'll help maybe clear up where some of these gray areas are especially in that right-hand column. And then that's what I'm hoping once we get that established, that we'll be able to make some little more clarity in that right area, so we know where the cutoffs are. So that's something hopefully come January 1st, they'll have it on your local Medicare carrier website. You can look for that. On the left side, they have an area that says audits. And if you go on there, they'll have an audit worksheet. It may take a little longer to get on there, but hopefully they'll have that not too far after the first of the year.
And then we debated whether to put this lecture this early for the fact that, Steve, correct me if I'm wrong, that there still needs to be some clarity in some of these areas, and you keep referring to like January 1st or the end of the year, but we also felt that it was that important to bring it to our attention, because I know as I was maybe in COVID times and I've been doing some live meetings and talking to people, well, this is how I built it this year, but then next year that's going to be different, and like 100 people staring at me like, what are you talking about? It's going to be different. Like, didn't you know that there's new guidelines coming out for 2021? So that's why we have this maybe a little early, but still, I think, good information to kind of get this audience thinking of that.
Correct. Yeah. I mean, Medicare's rule is still in the proposed rule state. Generally, November 1st, they will release the final rule and put it out. So watch for that, on November 1st or somewhere shortly thereafter. But I'm of the belief that you're not going to get this watching one lecture by me. I mean, this is something that you're going to have to kind of hear repeatedly. You're going to have to do it a few times. Hear it from some other people too. Get other people's opinion on it, because there is some little gray area. There's a lot of stuff to digest, and really the more you hear it and the more you look at it and the more you work with it, you're going to start to understand it and get it better. So.
Hey, Steve, why don't you go through this case? There's a bunch of questions in here. We try to keep these at about an hour and 40 minutes, and we're getting close to that hour. Why don't you go through the case? And then, Joe, I'll let you kind of be the keeper, because I've been watching a lot of other things here. Maybe you can then take care of some of the questions that I've rolled through. So maybe go through it a little bit quick, Steve, or a little faster pace.
I can knock this one out pretty quick here. So
okay, perfect.
Okay, so real quick, this is going to be basically a glaucoma suspect example who is also diabetic, and they also have cataracts. So you can see on this patient here, he comes in, there was really nothing interesting. He had pressures at 24, but we looked at his nerves and they were like really tiny, and he goes, oh yeah, I've had high pressures my whole life. I've been told that. So really we weren't too worried about it. We just said, okay, we'll follow you up in a year. So again, this is the old system coding. I'm going to skip over that right now. Or we have the option where we didn't know anything about it. He's never heard about it, or his nerves are a little questionable. So then we have him return for testing. So that changes it to where you could possibly use a 92,000 code, get paid a little more. But I'm going to go through the new coding here on this one quickly, because I think that's more valuable at this point. So here we have a patient with diabetes and cataracts. So we have two chronic stable illnesses. We didn't order any tests on the first example because, everything was fine. We weren't concerned about it. And he was a low risk of morbidity from diagnostic testing or treatment, which we didn't even really do any. So that first example would be a 99203, which actually with a new patient matches what we probably would have done under the old system. Now for the glaucoma suspect, we decided to order the 3 tests. So there we got our three tests ordered, and we still think but his testing came out normal, so there's still a low risk, but it doesn't matter. We have a 99204 if his testing all came out normal. But now the same patient, when he comes back in, we can bill all those extra codes for the office visit. We determine that we're going to start him for treatment. And I think I might have lost the page there. But anyway, with that, basically the only difference that makes on the other one is we're going to review the tests that we did today. If I go back, we'll have the same thing. The same thing in the left-hand column. We're going to review those 3 tests in the middle, so we'll still get that category 3, and we start them on drug management. So here's an example where for this patient, we would bill a 99214 without looking into the back of the eye or having to dilate them that day. So again, that's one that's going to be a little bit, we're going to have some examples of that where, we have to break some of those old mindsets that we have. Okay, and actually, we're going to go to this one here. So we're going to revisit our last sample billing question. So our last simple billing question. You see a new diabetic patient. You perform a comprehensive dilated exam. It's unremarkable. You tell them to come back in a year, and you send to PCP a letter. So which of those 3 visits would you guys bill now? So I'll let Greg pull that up. And while you guys are voting, I'm just going to say there's a lot more information in the handouts. There's probably another at least half hour, 45 minutes of information here. But I really thought it was important to spend time on the new codes and the changes. So you have all that in there. It'll go over some of the testing codes that are available. It goes over how to file post-op cataract glasses. It goes over modifiers like 25 modifier and 59 modifier. So you have all that access in the handouts there. And at the end, I'll put my email up. And if there's any other questions, you guys are more than welcome to shoot me an email and ask me any other questions about that other stuff that we couldn't get to.
Well, Steve, it looks like things have changed a little bit. If I remember correctly, things were at about 61% with the 92004. I think it was 16%, and it's still sitting at 16 for a 99204. And we've raised the 99203 up to 41% on this.
Good, and I agree. That's probably still the appropriate case here, And if we go back to you guys can kind of work that out on the, on the little chart that I gave you. But all we have is one chronic, stable illness. We didn't order any tests. We didn't order any treatment. So really, you're probably looking at a 99203 at best, especially with the new system with the new coding system that's coming out. So again, we're going to have to change our mindsets a little bit on this, and hopefully this is helpful. I think in the long run, this will be a really good benefit because we're not going to waste so much time just documenting check marks. We're going to actually get paid for what we're doing and what we're managing and what we're medically doing for these patients. But we just have to kind of change our optometric mindset of a comprehensive exam, a level 4 exam is a dilated eye exam, because that's going to kind of start going out the window a little bit with the way the new codes and the new thought process is.
Yeah, and you kind of showed an example of that where someone comes in and you're prescribing medication, and that could be a level 4, but we could have someone coming in with a PVD, let's say 6 weeks, everything's calmed down, but you need to have to dilate to make sure there's no tear back there, and there's no follow-up, and that could be a level 3 then. So, yeah.
But again, before everyone panics on that, just remember that we have to see where the fee schedule comes in, because from what I'm hearing, and it's indicating that even though some of these codes seem like we're being pushed down a little bit, there is going to be some kind of change in the reimbursement level. So a lower level code may actually pay more than what you're used to, in the past. So we'll just have to see how that pans out.
Joe, why don't you, if you've been monitoring the questions for Steve, please do that.
I will. Steve, will a retina? I think I might know the answer to this, but will a retinal photo suffice as a retinal drawing for these 92201 codes?
Absolutely not. A retina photo is a retina photo. If you're doing a photo, then you bill a photo. And actually, let me go back here. The payment levels on those two codes right now, I shouldn't have shot through this quite so quick, is you can see down there the peripheral extended ophthalmoscopy 99201 is about $27. The central is about $17, where your retina photo is still about $48. So retina photos have come down in what they reimburse quite a bit over the years, but you're still going to get paid a lot more for the photo. So you definitely want to do the photo.
And here is, I'm not sure, it's not really a technical question, but it might be a philosophical question. With insurances having such high deductibles these days, do you find it hard for people to get on board paying these bills?
Yes, that can definitely be a big challenge. And that's where some of the education is important. Taking your time to explain to the patient, why the visit is medical, what you're taking care of for them, how it works. What I've kind of found though is, a few years back, it was much more of a challenge, and maybe some of it too is because my practice has been doing this so long, it's gotten better. But I also find, patients are used to going to other specialists and getting hit with the same deductibles, the same co-pays, and really a good number of them don't blink too much. The ones that you have a little more issue with are the people that have no other health issues, don't see any other doctors and are just used to coming in and getting their routine eye exams done. That's where you're going to run into the problems a little bit more. And that's where patient education is key. Just, promoting what you do, what you're doing for their health care and what you're doing for their eye care. And, again, just explaining to people up front, this is going to your medical. There is a chance this can go to your deductible, if you have one. So, don't be too surprised if that happens.
Can you bill optical pachymetry? And I think that the question is pachymetry using OCT?
Yeah, that's always a tough question too, because technically the pachymetry code is an ultrasound code. So by the letter of the law, it's not correct. But by the, that's a real tough one. I mean, my feeling is pachymetry, again, that's one that's up on the chart there. I think it pays something like about $17 or $12 for a pachymetry at this point. So, I mean, if you do 50 pachymetries this year and you're doing the OCT one and you bill it and you get audited and they say that's not right, what are you going to pay back at most? $500. I think technically you shouldn't, but I don't sweat that one because A, it's a low dollar amount, and B, you're getting the spirit of the test that you're doing.
Steven, let me explain what I do in my practice. I love having my OCT optical, if you want to call it that. And the optical could also be done with an orb scan, right? Orb scan does the slit lamp and that's an optical. I'm guessing they're thinking, OCT here, optical coherence tomography, and obviously that gives a really accurate. Whenever I order it, I just have the technician do the OCT, and they go and they do a central pachymetry for me using ultrasound and write it on there. And so then, so it's just put the ultrasound unit in the office, right where the OCT is. Anytime you get an OCT and it gives you all the different parameters, I know what we're looking for. Just have them do a central if you want a way to do it. And to me, it's a nice way to double check the technician to make sure. You're always going to get a little thinner on your OCT because the pachymetry doesn't hit that 90 degrees. But that could be a way around that in a sense.
Yeah, and that's a way to cover your butt on it. Again, like I said, it's by the letter of the law, it's not correct if you're doing that. But again, you're talking such a low dollar amount test, and I just don't sweat that one that much.
It's a 765, right? So it's
yep.
Code, so.
Yeah. Yep.
See, for the diabetic patient exam, would order refraction be considered an order test?
I would say no, because the refraction. Even though, I will not argue with you that the refraction, the visual acuity, the visual status of the patient is of course very, very important and can be very diagnostic. It's not considered a medical test to determine the status of the disease. So I would say no.
Okay. Will the new changes that you discussed affect other vision plan insurers like iMed and Spectera?
I mean, by theory, it should if they're using those codes. But as I said earlier in the presentation, vision plans generally use CPT codes that are medical and try to make them fit in for a routine eye exam. So my guess is what I'm saying here, lecture-wise, isn't going to determine, or they can't come to you and say, oh, you don't have this medical decision-making level, we're not going to pay you for the exam. A routine eye exam benefit is a routine eye exam benefit. So long as you're meeting the elements of what they require for an eye exam for their routine benefit, you should be fine. And if they require you to use a 92,000 code or a 99,000 code to bill that, again, it's not medical. So all these rules and dictations, even though they shouldn't be, are out the window.
I think we're getting pretty close to our time.
Okay.
Great. Yes.
And I do have my email up there, so feel free to email me if you have any other questions, and I'll try to get back to you at a pretty expedited pace on that. And one other thing I can comment on, being part of the Pennsylvania Optometric Association, we actually have an in-house electronic claim service which is kind of why, we with our strong third-party center and our strong billing and coding background, we do have a service that will actually file claims for practices that need help or have issues with it. So that's some place you can look if you're struggling or looking for a bill or need more information.
And that goes beyond Pennsylvania. You don't have to be a Pennsylvania member. We get plenty of people from outside the state. So.
Mm-hmm.
All right, I'm going to see if these slides will launch here from my standpoint. And Steve, I want to thank you for tonight and doing this presentation, a common sense approach to medical and billing and coding. Obviously, this is the tip of the iceberg that you've talked about, but I think your title is perfect, a common sense approach to this, and it's just the tip of the iceberg. So thank you for being here.
Yep. Thanks, Greg.
Yeah, you're welcome. For those who are out there, we will have some upcoming live events. We sat today and discussed that. So obviously now the CE has ended. Webinars and will be launched, and there will be plenty of Florida webinars coming up in December now that Florida is allowed to do that. And there will be enduring learning on the website. So everything is at the website. Just pay attention there. And regarding housekeeping, just to remind everyone, Vanessa is our engine. She's working behind the scenes as we speak. And she will upload, for those out there that have COPE and ARBO, we have your numbers, your OE tracker number. We will upload that to ARBO and COPE. I know that there's plenty of Florida docs on here tonight. We will upload that to your Florida board website, or Vanessa will do that. There's always a question about, will you get a certificate? You will get a certificate sometime this week or early next week that Vanessa will send out. There's a lot of people on this webinar tonight, so the certificate will be emailed to the email that you use to watch this webinar, because sometimes people have 2 or 3 emails and they're like, I never got it. Well, you use the other email. And then please complete the survey that was probably been emailed right now to the email address that you used. That's for regulatory purposes, and Steve also asked for a little bit of extra feedback on that. So with that being said, I'm going to stop. Joe, if you want to make some final comments. Steve, I see you're still on. Is there any final comments, Steve? Then I'll turn it over to Joe and we'll wrap it up.
No, just want to thank everyone. Thank you guys for the opportunity out there, and thank everyone for some good questions. I always think the program goes better when I'm answering questions than just talking at you. So thanks for your input on that.
Well, Steve, I think you did a terrific job, and I personally learned really quite a bit. I want to thank everybody for attending and giving us 2 hours of your attention. Now that Florida is allowing some online education to fill out the last few months of our biennium, we will be having online Florida-approved CE for your relicensure, not just practice management, but clinical education, medical errors, and jurisprudence, and we will be beginning that right about December 1st, which is the earliest that they will allow through the end of the biennium. So if you know that you need more hours clinically, including TQ or any of the other required courses, we can take care of you. So with that, be safe, and we look forward to seeing everybody in person very shortly.
Bye-bye, everyone.